Of course, I get lots of questions about CBD products, but thanks to all those claims being made, people are terribly confused, and it's difficult to answer some of these questions with certainty. The clinical science is not quite there yet, but certainly the anecdotes are coming in, and I've connected with an Oregon-based company that is all about high-quality ingredients and manufacturing standards, not hype. Previously, they were called Select CBD, but they've just relaunched their brand as SocialCBD. SocialCBD focuses on broad-spectrum oil, something else you might have heard about, but maybe equally confused. So let's start with that. Hemp has over 60 non-psychoactive cannabinoids, and CBD is just one of them. Broad-spectrum oil goes beyond CBD isolate, contains additional active compounds that can work with the CBD to create what is known as the entourage effect. This can more effectively deliver some of the calming or relaxing effects that many people are looking for or experiencing. SocialCBD's broad-spectrum oils contain zero CBD, so there's no rewarding effect. They're available as great-tasting tinctures in great flavors like vanilla mint, pomegranate tea, Meyer lemon. Simply drop it under your tongue for maximum effect. SocialCBD products are in a range of formulations, each of which is clearly described, so you can make an informed decision without all the promises that sound too good to be true. To learn more, go to drdrew.com/socialcbd. That is our site. drdrew.com/SOCIALCBD, and for a limited time, you can save 20% at checkout with the code DRDREW, DRDREW. So it's drdrew.com/SocialCBD, and then Dr. Drew at checkout. Opiates, opioids, and the problems they cause are in the headlines daily, but this drug's use actually started thousands of years ago. In this week's episode, we will explore possible solutions to the opiate crisis with excerpts of guest interviews with author David Sheff, Dr. Bertha Madras, Dr. John Kelly, and Dr. Anna Lembke. And now DRDREW.com presents The History of Opium. Now, as with any crisis that involves complexities like those presented by the current opioid epidemic, there is no single concise answer as to how to fix it. Many things must happen before our country overcomes this problem, and we have to recognize what it will take to prevent it from happening yet again. Dr. Bertha Madras?
What I'm finding is that everyone is looking for the federal government to fix the problem, solve the problem.
Oh boy.
And my feeling is that this problem has to be solved at every layer, every sector of the nation.
Mm-hmm.
It's essential. We're going to have to change some medical practices. We're going to have to infuse a lot of money into the problem from the federal government. But parents are going to have to get the message as well. And the message is to just denormalize chemical coping and chemical reward from their teenagers' lives. And these are issues that will haunt us for generations unless we begin to change the culture.
Unfortunately, we're in an era where taking pills to deal with everything and anything. And oftentimes, physical conditions that can cause pain can be mitigated or even cured with treatment other than opiates, including counseling, physical therapy, lifestyle change, just to name a few, biofeedback, all kinds of things. Unfortunately, fast-paced demands of work and family typically result in patients opting for an easier, quicker, less expensive, of course, insurance companies love that as well, just prescription drugs for everything from minor aches and discomforts to severe pain and emotional pain. Now, how do we get here? Well, the terrible combination of physicians wanting to help patients while being forced to turn them over quickly by insurance carriers and their medical agencies, and patients who expect immediate relief and believe that their doctors are giving them the best treatment no matter what and have an expectation of getting a medication when they come to the doctor. This all, and the duplicitous behavior of drug companies, has resulted in the widespread misuse and abuse of opioids. Thousands of times across this country this has happened, probably millions. These drugs are an important tool in the medical community's arsenal and are very effective for treating pain, but are also highly addictive and, given the right circumstance, of course, subject to abuse. Many people unwittingly fall into the abyss of addiction because they are given a prescription for OxyContin or Dilaudid or other opiates to deal with post-surgical pain, say, or a sports injury, work-related injury. And while these prescriptions are appropriate in many circumstances, in some of these situations, they certainly could have been treated with less potent over-the-counter products, but they also don't need to be sustained for a long period of time. Because people typically don't challenge a physician's recommendations, they dutifully take the prescription, and after finishing a course of these powerful medicines, sometimes they find they can't function without them. They don't realize they're in withdrawal, the pain gets worse, so they head back to the doctor and ask for more pain medicine. Once the withdrawal kicks in, physicians who don't see this as withdrawal prescribe more drugs because they see them as being in pain. Then also the patient describes sleeplessness, so they have to kick in some benzodiazepines. All the while, they're just treating withdrawal symptoms, but in the meantime, they're combining a benzodiazepine with an opiate, which is a lethal combination, which we discussed at length, and has to be addressed if this crisis is ever to be solved. Additionally, major changes must be incorporated into the practice of medicine, the way insurance companies operate, and the method that drug companies use to develop and distribute their drugs. Sweeping reforms in all areas is vital, but ultimate success is hinged on transforming the patient, right? All of us, we're all patients, and our expectations have to shift. The United States has endured several periods of widespread what's called iatrogenic addiction that is caused by the medical system or the doctor. It could be argued that the previous period of widespread use following the Civil War perhaps was due to inadequate medical training or excessive enthusiasm, less governmental oversight, remember the patent medicine era, and given a genuine desire to cure patients. But it can also be argued that what we learned from these episodes can have served as a blueprint for how to avoid the current and most devastating crisis to date. Opioid abuse disorders cost our country billions of dollars annually and result in thousands of avoidable deaths. Here's a partial list of areas that should be addressed in order to combat the crisis. Many more are not listed here, but perhaps these can begin to spark some discussion. For starters, stigma associated with addiction must be dismantled. The DSM-5, which is the American Psychiatric Association's reference book, identifies 10 classes of drugs associated with what they now recognize as substance use disorder. I just call addiction. These range from caffeine and tobacco to opioids and hallucinogens. Now, some of these are addictions and some of these are just abuse. Remember, addiction is a disease where you can't stop even when you want to. Understanding that these disorders are not moral failings, also critical to dealing with them. It's true that a recreational user made an initial choice to take an addictive substance illegally. These drugs can then quickly hijack the wanting system of the brain, resulting in a stunning downward spiral that renders the user defenseless. In other words, even though you don't like them anymore, you still want them. Now, most people don't realize the potential of this consequence and are unprepared to deal with the enslavement that can occur. The population of recreational users, as well as those who have been prescribed medicines, are both vulnerable to the pitfalls of taking medication that have addictive properties. We've got to reframe the way we talk about these disorders and the people who are battling them. We need to make the system that are already in place more effective. We live in a world that operates and relies on technology to run smoothly, yet systems that are in place to prevent drug abuse are not yet functioning to their fullest. The prescription drug monitoring programs, these are electronic databases that track prescriptions of controlled substances. They're out there, but they're not widespread yet. Theoretically, a provider should be able to enter a patient's name and instantly find out if he or she has prescribed similar medication from other doctors. It's not always the case. Again, HIPAA and privacy issues are getting in the way here. Historically, the system has been patchy, cumbersome, and inaccurate, so physicians often have bypassed it in the past in order to spend more time with their patients, which is what we feel our job is. Despite its shortcomings, the states are making progress and streamlining the tracking process. Hopefully, the system will become more precise and serve as a reliable system for providers in the near future. Increase education for providers. In a perfect world, physicians would have as much time as they need to assess a patient's case. This would culminate in a proper diagnosis, thorough explanation, all the treatment options, education, careful follow-up. And if pain is part of the patient's complaint, non-addictive analgesics should be considered along with other types of therapies and perhaps psychological services. All avenues need to be investigated because pain has a physical manifestation, but there are other aspects of pain, the so-called affective part. In other words, pain has a somatic component, what it feels like in your body where the pain is coming from, and then what the pain does to you, the misery index. If opioids are necessary, they should be prescribed in low doses and for very short periods of time. Thoughtful consideration should be given to every patient's drug history and current prescribing as well. But we don't live in a perfect world. People want quick fixes, and physicians are hamstrung by insurance companies and overhead costs. Prescription drugs treat the pain effectively, and physicians need to process patients. So, nothing ends a patient visit quicker than opening a prescription pad, so powerful opioids are often prescribed. Some doctors may deny more opioid prescriptions after the initial one runs out, but others continue filling them, and this is how we get into trouble. An article published in the Journal of American Medicine in 2014 found that 75% of heroin users in treatment started with prescription painkillers. This is data that suggests once we discover somebody has been abusing medications, we are orphaning these patients as opposed to getting them into proper treatment. Many substance abusers can continue down the path until they are destitute, estranged from their family and friends, incarcerated, institutionalized, or dead. Those who seek help may consult a family doctor first, though this is a first step. Most family physicians are not really qualified to treat addiction. And unfortunately, they don't always acknowledge this deficit and try to treat it anyway. This is an important moment in a patient's recovery because unintended mistakes may be made and can have lasting impact. Dr. Anna Lembke.
I personally think that one of the biggest reasons that we're seeing a decrease in opioid prescribing now is because physicians have been publicly shamed. And I think without that, I'm not sure we would have made any headway. That it really took, doctors being shamed in the media for the problem of overprescribing for doctors to really take it seriously. And that's not because doctors are bad people or even that the majority of them are pathological narcissists or even, I think even just a small minority of them might be pathological narcissists. But I think, unfortunately, it took that because there are so many invisible incentives driving overprescribing. There's the very little time to see patients. There are all kinds of billing incentives to prescribe pills instead of talking to patients. And of course, there's natural and healthy narcissism. And by that I mean that we all can experience a narcissistic injury if if our sense of competence is injured in anything that we've invested ourselves in. So whether we're trying to be good parents or good bird watchers or good doctors, if our competence is threatened, we experience a narcissistic injury in that regard. And so, of course, interacting with patients, doctors become doctors because they want to heal their patients, and when patients express gratitude, they feel really good about themselves and feel like they're doing a good job. And when you prescribe opioids for pain, initially they really work and patients express gratitude, and that feels good for doctors. On the other hand, if you raise the possibility that the patient is misusing the opioid, patients get angry, they don't like to have that discussion, and then that doctor's competence is threatened. So it's along those lines, I think, that is the psychodynamic element that doesn't get talked about very much, that makes it really hard for doctors to confront their patients around misusing the pills that they're prescribing, and really incentivizes doctors to continue to prescribe a pill that a patient endorses is helping them.
For instance, would you let your dentist give you a heart transplant? Well, of course not. Would you just consult a dermatologist about a detached retina? Well, even though the first stop in treating a substance use disorder might be a family doctor, he or she may not be that skilled in this. Most people don't know that this is a specialized area of medicine that requires specific training from people who have been trained and do it for many, many years, typically in teams. Some patients are unable to stop using drugs. They could have other psychiatric problems, they can have no resources, and will only stop when they're put on medication-assisted therapy like methadone or Suboxone. These drugs are attractive to patients, and they help manage discomfort and cravings and withdrawal, but they're also opioids. They cause physical dependency. They're also highly addictive, and they come with their own set of problems. Most people these days seem never to get off them, and shockingly, many physicians who prescribe these powerful drugs have only had a few hours of training online before doing so. The government is encouraging doctors to prescribe to literally hundreds of patients. I, who has had many, many years of experience, I don't believe I can handle more than about 30. Physicians also need to be knowledgeable about the community resources that are available so they can make appropriate referrals to patients such as mutual aid societies. Many professionals who regularly deal with addictions believe that harm reduction is the best answer for people with chronic problems. They argue that drug abuse cannot be stopped, that the risk of death is too high. They promote syringe exchanges and wider distribution of naloxone. This is a life-saving drug that reverses the effect of an overdose. Many experts also favor drug checking, a system that tests drugs for dangerous contaminants prior to ingestion. One of the most controversial ideas currently being implemented in Vancouver, British Columbia, is the Providence Crosstown Clinic. They dispense legal-grade heroin to approximately 150 patients a day who come to inject themselves under medical supervision. This program prevents death from overdose and allows patients to access drugs legally without having to steal or commit crimes. And if you think about it, it's not different than methadone or Suboxone. It's just giving them their heroin. Legal regulation of heroin and other illegal drugs offer a safer version of what they can obtain on the streets. Now, this may sound problematic, but it actually doesn't differ from other medication-assisted therapies. Opiates and opioids are the same despite how they're dispensed. In fact, several countries have already instituted shooting galleries where people can use safe drugs and also be put in touch with medical professionals and social services. So while they are giving them their drug of choice, they can help them motivate change. Most experts would agree that access to good treatment programs is critical for anyone who is suffering. This includes everyone from the stay-at-home mom who's dependent on OxyContin for chronic back pain to the inmate who got hooked on Suboxone in prison prior to his release. We need to develop more effective medicines and modes of treatment. Researchers are developing new medications that will address different aspects of the problem, including biologics such as vaccines and monoclonal antibodies. These may eventually be used to treat people who suffer from substance use disorders. Medication made with abuse-deterrent formulas are an important part of the puzzle. It's also important to remember that there will never be a magic bullet that just solves the problem. Each person who suffers from addiction comes to it with his or her own history and constellation of contributing factors. The reason people get to addiction is they have trouble regulating their emotions, and that's why they reach for drugs. That problem doesn't go away just because they get off opiates. And their brain may have been permanently altered, so they now have a second problem. They have addiction. The effectiveness of mutual aid societies cannot be underestimated when it comes to treating addiction. 12-step and other similar support programs typically do as well or better than professionally managed treatment when it comes to abstinence as your goal, and are critical to the success of essentially all patients. There just aren't enough professionals in the world to give addicts the kind of support they need to get through particularly the early part of their recovery. Addicts are given the opportunity to advocate on behalf of their cause and serve as mentors for others. Eventually, being of service is how they stay sober. Dr. John Kelly.
So some of those would be things like recovery community centers. So these are like senior centers, but for people in and seeking recovery. So we are just doing, for example, the first big study of these in New England and New York State. So these are places where people can go during the day. They can find support for recovery, instrumental support in terms of linking people to jobs, employers who will take people with criminal records, for example. They'll be taught how to put the CV together, a cover letter. They get support there for young moms in recovery. They can get access to recovery coaches who are recovery mentors themselves in recovery that can help them navigate the system, the treatment system, and recovery support service system. So that's one entity that's come around. There's recovery residences, of course, have been around a long time. There's now good empirical support and cost effectiveness of these. Recovery high schools, collegiate recovery programs, mutual aid organizations like AA, NA, LifeRing, Smart Recovery. All of these kind of community-based entities have grown in the last 30 years in particular.
These programs are vital. They can make important contributions to the patient's recovery, particularly when a warm handoff is initiated. In other words, rather than just telling somebody they need to go to a treatment program, or rather a 12-step society, somebody from that program introduces themselves, shakes their hand, and says, "I'll meet you at a meeting tonight." Attendance is very high in that case. Dr. John Kelly.
And here's an example of a very well-done study that was done that really demonstrates this principle of a warm handoff. It was done in 1981 by Sisson and Malams. They did a randomized study where they randomized people who'd never been to AA or 12-step groups before. They were leaving treatment, and they were randomized either to just encouragement to attend, so it would be giving them a meeting list and saying, we'd strongly recommend that you go to AA and NA and groups like that because they're going to help you in your recovery, versus the other group that patients were randomized to was the same thing, but in addition to the meeting list and the recommendation to attend, they were asked to get on the phone with a current member who agreed to meet them and take them to a meeting. They followed them up for 1 month to see how many people in each group got to their first meeting. And so a simple study, and basically what they found, and again, these were people who had never been before, okay? So had never been to AA or NA before. So in the standard referral group, where they gave them a meeting list with clinical encouragement to attend, nobody attended their first meeting. Nobody went at all.
Crazy.
Zero. In the other group, every single person went. In fact, they went to roughly 2 to 3 meetings in that first month. The advantage of having a peer who, as part of a clinical team or as part of a recovery community center team, that can help people get and stay linked into, via building rapport, breaking down those barriers of stigma and discrimination, which often people with addiction problems feel. When they're able to connect with somebody who's been there, trodden that path, has that lived experience of active addiction and recovery, they're more likely to get connected and become engaged in that free community resource. They also confer a very large economic benefit. So I describe this as really the closest thing in public health that we have to a free lunch. Now, here's why. In a study that was done in the VA system, which obviously is the largest healthcare system in the world, and they are incentivized, because it is a national healthcare system, they have a natural incentive to maximize quality and reduce costs. And so one of the big studies that they did was to actually do a comparative evaluation of treatment programs that strongly encouraged linkage to AA and NA versus did not. So they compared those two different types of programs. When they looked at their clinical outcomes at 1 and 2 years after treatment, they found that, in general, patients coming from these two types of programs, one that strongly encouraged AA and NA participation and one that did not, they found that the patients coming from the programs where they were strongly linked to AA and NA had significantly better abstinence outcomes. Otherwise, the outcomes were similar across programs, so they had higher rates of continuous abstinence by about 1/3.
Wow.
But here's the thing. What they also found was that, on average, it saved about $10,000 per patient over this 2-year period. Jesus. In terms of reductions in healthcare resources, because people were utilizing these free, ubiquitous, indigenous community recovery support services, namely Alcoholics Anonymous and Narcotics Anonymous. So essentially, if you think about that's $10,000 per patient and improving outcomes. If you multiply that by the roughly 1 million or so just with an alcohol use disorder who get treated every year, that's $10 billion in savings.
Phone apps like Advocate and Companion are providing new e-tools for people who are dealing with addiction. It's not clear yet whether they will have great success, but people are working hard on these kinds of programs. Efficient and effective governmental intervention and oversight is critical. In 2017, the Department of Health and Human Services declared the opioid crisis a public emergency and announced a 5-point strategy to combating it. This came on the heels of new opioid painkiller prescribing guidelines that the Centers for Disease Control released in 2016. This was an attempt to slow things down, and several high-ranking government officials are sponsoring legislation to deal with this epidemic. The government is making a difference, particularly through the Justice Department. In conclusion, the current opioid epidemic is a result of many factors. Some of these are innocent, some nefarious, but they all have conspired to create a mess. The United States has weathered several drug epidemics during the course of its relatively short history, yet we seem to fail to learn from previous history. Dr. John Kelly.
We can get, disheartened perhaps as clinicians or as family members when we don't see our loved one or patient getting well as quickly as we might want. But when we zoom out and we look at the bigger picture of what actually happens clinically in the clinical course of an alcohol or other drug use disorder, we can see a fairly long-term view. And I think this is where the idea of a chronic illness comes from. Basically, when we look at studies of people who have substance use disorder and look at their clinical course, what we see is that it takes about 4 to 5 years after the onset of their disorder before they will start seeking specialty treatment. So that could be some kind of outpatient treatment, speaking to a provider, attending a mutual health group, to some kind of formal or informal intervention. It takes about 4 to 5 years after the onset of the disorder. Now, part of that delay, of course, is the stigma and discrimination and shame that people feel when they have this disorder because they see other people being able to control their alcohol or other drug use, but they cannot. And there's a lot of potential negative consequences which could come about as a result of acknowledgement and disclosure. So try and keep it hidden. When after that 4 to 5 year period, they find that they are unable to go on any longer, or there's some kind of intervention by the criminal justice system, like a DUI or something that brings them into contact with the treatment system, it still takes about 4 to 5 treatments and about 8 years on average to achieve 1 year of full sustained remission.
In society's collective hubris, denial, whatever, it's the result of unbridled greed, shoddy science, less than truthful sales tactics, the desire to help. Is it the physicians, the patients, the drug companies, the regulation? It's all the above. We've failed to recognize the signs of an impending crisis when it was coming, and all parties are culpable. Some experts in the field argue that drugs are a normal part of the human experience, that we must abandon a notion of a drug-free society. They purport that such a goal is not only unrealistic, but it's impossible, and advocate for the development of strategies that promote responsible use. Socioeconomic status is also an important indicator for the potential for developing substance use disorder. Abuse rates are higher in poorer communities because of childhood trauma, mental illness, unemployment rates, violence. Blue-collar workers experience more job-related injuries and therefore more vulnerable to developing dependencies on painkillers. But this doesn't have to be this way. People need to be made aware that this opioids, though they feel better in the moment, are not the answer. Dr. John Kelly.
I mean, I think we have to look much more broadly at, because this is the top public health problem in the country, it's actually the top public health problem in most middle and high income countries around the world.
My guest, Dr.
And it
John
confers
Kelly.
a
Tune in next week when we wrap up our history of opium by looking at use prevention
that really,
and
our
the government's
professional
response to the
treatment
opiate crisis.
system can do a lot.
Michelle Poe and the staff of DRDREW.com
cannot do everything.
You
and
may
this
read
is why
it in
we
its
need all the
entirety
help
at
that we can get.
DRDREW.com.
The medical community
Thank you.
needs
We'll
to
see you
offer
next time.
reasonable and effective alternatives, and patients need to understand that living with a certain amount of discomfort is necessary. When Freud first got to this country, he discussed the term ordinary misery. We have become intolerant of ordinary misery in this country. And if you're a parent, it's imperative that you teach your children about the risk of taking and mixing narcotics.
David Sheff.
Parents, first of all, we love our kids so much, and we're so terrified that something is going to happen to them, something bad. And so we want to look at the good stuff, sort of celebrate, our kids' accomplishments, the funny things they might say to us, their awards, their athletics, their grades. And we're also inclined to push aside and deny a lot of the things that suggest to us that maybe there is trouble. And so the first thing I would do is say, no, don't do that. A pediatrician said to me, if you think there's a problem with one of your kids, there probably is. And so, we shouldn't ignore it. We should go find out. We aren't expected to be doctors, but we are expected to know to know our kids. And so the point there is that we want then to bring our children to see a doctor, to see a therapist, to help us figure out what's going on. Is a child just shy, or maybe sad sometimes, because our kids have to be sad. We have all kinds of kids. Some are extroverts, some are introverts. But what's the difference between that and a child who might be suffering depression? Again, we don't know the answer to that. That's why we have to rely on professionals. The other thing is that we have, when a child is using drugs, when we're worried about them, when their drug use is escalating, we need help ourselves. We can be completely overwhelmed and scared, and we don't know what to do. When this happened to me, my family, I wasn't sleeping, I wasn't able to work, I wasn't able to take care of my other children. So we need help, and whether that means going to therapy, family therapy, Al-Anon meetings, we have to take care of ourselves if ever we want to be able to help, the person that we love who's addicted.
There are appropriate uses, for sure, but they reduce suffering, as we've said over and over. But just because, say, your son has wisdom teeth removed does not mean that he needs a powerful narcotic necessarily. Some over-the-counter options often do. You're the most important steward of your health and the health of your children. Educate yourself, educate your children about the inherent dangers of pills. Get out of the idea that pills solve every problem, and teach your kids about that. Some of the conversations might be uncomfortable, but it could save lives.
I want to thank my guests, Dr. John Kelly, author David Sheff, Dr. Bertha Madras, and Dr. Anna Lembke. Tune in next week when we wrap up our history of opium by looking at use prevention and the government's response to the opiate crisis. I want to thank Michelle Poe and the staff of DRDREW.com for helping pull this series together. You may read it in its entirety at DRDREW.com. Thank you. We'll see you next time.